when I look back on it in that first year of starting a business, I didn't know that that's what I was going to do.
No.
I just had this idea that I would still create some sort of magic between the disciplines and get people together in collaboration, which has always served me well. It's an intuitive way to work. It makes perfect sense to me, but it's so hard to achieve in healthcare because we're all sort of trained in silos of this is your specialty, this is what you do.
My guest today is Eleanor Clausen. She's the founder and CEO of the International Spine Centre, or TISC, a pioneering medical organisation with a collaborative approach to treating spinal disorders and pain management. The business's novel interdisciplinary model is designed to help patients experience life beyond pain. In addition, Eleanor founded 3D Research at TISC in 2022, an international research company focused on academic publication, clinical inquiry and innovation. 3D represents the company's philosophy of discover, develop, deliver, the three tenets of research methodology. Eleanor's career has been shaped by her creativity and thought leadership and backed by her focus on implementing people-centred change. She has a wealth of experience across clinical nursing, research and education in both public and commercial organisations, including re-engineering patient-focused care in neuroscience, which was rolled out across multiple regional health boards in the UK, pioneering design and development of the Edinburgh Pain Assessment and Management Tool, which remains the only validated cancer pain assessment tool globally, collaborating with regional health networks to deliver improved outcomes in chronic disease and strategic local and national and international levels with GSK. Welcome to Hacking Health. This podcast is for future-focused health experts, thought leaders and change makers who are interested in making health accessible for everyone, because together we can get to the future faster. What do you miss most about living in Scotland?
Sarah, it's a big question, and I could talk a little bit about haggis and lots of Scottish things, but what I think the thing I miss most is the quirkiness of Scottish humour. And you never are truly appreciative of the cultural differences until you move your life across the world, and I adore Australian humour as well, but there's, a certain type of Scottish humour. Billy Connolly would be a very good example of that kind of humorous storytelling. It's just, and you're just killing yourself laughing. I sort of sometimes miss a bit of that.
Yeah.
It's a certain art I think the Scots have of telling a self-depreciating story or an observational story, which is funny.
That you don't find here.
Well, you do in parts, but
Yeah.
not. I think the Scots have a certain kind of way with it. It's maybe the accent, I don't know.
It might be the accent. So, I don't think I've ever talked about the fact that I grew up in Scotland as well.
That's right.
And something that was very odd was that I went to the same primary school as your partner, and in business and in life. So
it's so funny.
I know. It's like we think about that sort of thing, all the connections in Australia because it's such a small country, but it transcends borders.
True.
What was your dream job when you were a child?
In all honesty, I can tell you that the only thing I had ever wanted to be from being a very young child was a nurse. And it stemmed from the amazing British Ladybird book Off.
Oh.
And I had the Ladybird book of the nurse.
That's so influential.
And in that little book, there were all these amazing pictures of the nurse, in her uniform and her red cape and everything. And I also had the Ladybird book of Florence Nightingale. The images within those little children's books really, really influenced me. And my mum found them in her attic a few years ago and sent them to me in Australia. And I've got my name written on them. And I use it in a slide sometimes when I speak, because we can underestimate the power of nursing within society. Sometimes even the story of Florence Nightingale and what she achieved in terms of the modern nurse, like the school of nursing, the training of nurses. She She was influential with Queen Victoria to achieve that. And so for me, that's all I ever wanted to be.
I think Florence Nightingale kind of worked out germ theory and all those sorts of things, didn't she?
Incredible.
She was really very influential.
Right. So washing of hands.
Yeah.
That was Florence Nightingale, because the doctors weren't washing their hands between examining in the bed. It's horrible, but they didn't wash between examining patients. And she then realised these patients were getting infections. And so there's a lot in there about the story of flow. But that was my dream, my influence. And then I got to 17, applied to the nursing schools in Edinburgh, and that was the path of my life.
So that was how it started, obviously. It's transmogrified a little bit from there. Yeah. So you moved from clinical work to education, change management, and now executive management, really.
Yeah.
How did that process happen?
It was interesting because I would say that late 80s, early 90s in Edinburgh, nursing was a heady time for us. I didn't ever have a linear nursing career. Opportunities came just through networking and relationships, and I don't know, I was a rebel, Sarah. I was a rebel. I would look at things with patients and think, can we do better? How could we do better? And I, wanted to be a neuroscience nurse. I was really passionate about neurosurgery. I just loved it. It was tough. And the anatomy was hard to learn. And then I did my neuroscience training in London and came back to Edinburgh. And during that time, opportunity came to employ some management consultants. The chief nurse of Scotland, I wrote a letter to her, and with my nursing manager, we started a project, and we got the first funding in Scotland to do a re-engineering project, which was amazing. And these management consultants came in, and I got to come off the wards and worked as a project nurse. And it was hugely creative, and we did all these time and motion studies, and it was humbling in a academic national neuro unit to hear the patients' stories, and some of the things that you think you know really well about your own specialty and your own unit. We discovered in the time and motion studies that the most communication with a patient was through the ward domestic and the porter. You think it's going to be nurses and doctors or allied health or the physios or the OT or the speech therapist or the dietitian and whatever, but no. And we started looking at agile processes. So that work stood me in good stead for the implementation of strategic change management in documentation design, care pathways, all of these things. And also the advent of advanced clinical practice nurses and nurse specialists, and the ability to look at a sort of hybrid role between medicine and nursing. And so I became one of the first in Scotland in that role. And that was radical, really radical, to come out of uniform and be this, sort of person so close to a patient and their family, and with a whole range of clinical tasks that the neurosurgeons at that time taught me, which nurses didn't do, So it was really exciting. And that led to lots of papers and presentations and opportunities to speak at, medical meetings where nurses had never really been afforded time, and sort of flying the flag for the impact that I suppose as nurses we could have.
That hadn't been appreciated before.
And going to Europe and speaking and encouraging all the junior nurses as well in presentation skills and that sort of can-do attitude.
Love it.
That was me through the 90s and 2000s.
And so then what led you? I suppose the next step of that is your entrepreneurial life, where you established a private practice and
came to Adelaide.
Yeah, came to Adelaide, and it's a different sort of practice as well. So tell me about that. So
I'd spoken at the British Pain Society in London on cancer pain because I'd been doing a bit of work and had been involved in a major opportunity of designing a cancer pain assessment tool. The cancer pain assessment tool is called the Edinburgh Pain Assessment Tool and remains the only validated cancer tool for assessment in the world. And I bolted on algorithms of management. And in the audience were some doctors from Adelaide, And then they discovered when they got back to Adelaide that the neurosurgeon that they were working with in the pain unit, who was a pain fellow as well as a neurosurgeon, had worked with me in Edinburgh. So there was this sort of funny connection like we've just spoken about with you in Edinburgh and Adelaide and everything. And some of our trainees used to come for a year to Adelaide, and they invited me over, and I did a piece of work at that point in SA Health. And I sort of then came back to do another piece of work looking at disciplines and how we could all work together closely. And then the neurosurgeon then convinced me that I really ought to come to Adelaide. And I was a bit shocked, but he convinced me to come. And so I applied for a nursing visa and jump over the world. I sat in and listened to patients in that first year. So say I've been in Adelaide now 11 years, and the company International Spine is 10 years old. But in that first year, I just sat and listened to the patients. And I was just really compelled to be able to do something different for them in this city. And so I started the business on the extension of my credit card because I couldn't get a business loan.
Wow, you were a new arrival.
And that was this entrepreneurial thing of, you know, these patients the care seemed to me to be so fragmented. They were jumping all over the city across all these specialties, sometimes really unaware of their diagnosis and what the treatment plan might be. And I thought, gosh, it's just like being a pinball in a pinball machine. And some of the specialties don't speak to each other. There may be very limited communication or clinical letters. And that's when I really started thinking about what could I do, taking that breadth of knowledge in my career and change management and, the delivery of care. What could the model be? And then that advanced practice in nursing, could I achieve it? I could achieve it in Australia by starting a business, because really you don't really see so much nurse specialty or advanced practice. The healthcare system's so different compared to the US or Europe.
UK,
So the easiest way for me to really affect change was to start a company. And I did.
I know, it's like, I feel like you always had this understanding or drive to be able to do things differently for better outcomes, even like when you were very first practicing as a nurse. But then being an entrepreneur, you really can take it to a whole nother level, can't you? Because I mean, it's highly regulated industry, but you can invent things that have never been done before, like International Spine is.
That's right. And so the interdisciplinary model is a novel model. We see some probably more limited examples of it globally, maybe Sweden or the US and whatever, but not to the degree of the experimentation that we've had at International Spine. And when I look back on it in that first year of starting a business, I didn't know that that's what I was going to do.
No.
I just had this idea that I would still create some sort of magic between the disciplines and get people together in collaboration, which has always served me well. It's an intuitive way to work. It makes perfect sense to me, but it's so hard to achieve in healthcare, because we're all sort of trained in silos of this is your specialty, this is what you do. But in general, talking about healthcare, if we look to other industries, you can see that the model's applicable. Whether it's an architectural practice where you have an interior design, an engineer, a landscape designer, a builder, the operating model of an interdisciplinary practice and the change in culture, perhaps the energy that it takes as a leader to create the culture where people are prepared to reduce perhaps some of that professional barrier for the good of the customer.
It's thinking differently.
So that, for me, it's the patient is
putting
always
them
in the middle.
First. Yeah.
And the services can rotate around that patient, but they're all held together by an operating system, which I call the 3C approach, which is, about collaborative care. But creating that culture has been an enormous business challenge and enormous personal energy. Are we swimming against the tide in the way that healthcare is delivered in terms of, models of care delivery? And so I really needed early adopters in in the first couple of years, and it was really very, very difficult to achieve that.
Yeah.
You had to have people that would believe in the vision.
And you've got to sell that vision as the leader.
Yeah.
So we're talking about health tech a little bit and med tech on this podcast. Yeah. And I was excited to talk to you because you talk so passionately about a particular robot that you're hoping to bring to Adelaide.
Absolutely.
Can you talk a bit about that?
So I think as a futurist leader, we can talk about care delivery models and customer experience and all of those things. But in addition to that, technology is just the speed of technology is just fascinating. And we should always be open to adopting new techniques in patient care. And what's been challenging is that in other areas of the world, technology is really being adopted at quite a pace. And Australia has been adopting, and some regions of Australia has been adopting some of the more contemporary technology. But in Adelaide, so far, we have been early adopters of some robotic.
I remember the Da Vinci.
Yeah, the Da Vinci. And Adelaide was the first city in Australia to have the Da Vinci. It was a philanthropic donation that enabled that to happen. And it's quite a different robot to the spinal robot, because the spinal robot is a navigation platform as well, integrated with it. And to my learning was fascinated me because it's actually called a cobot, because it is the collaboration between the human and the technology. So the technical term is cobot, and the surgeon is always in control of it, because the navigation platform allows that, like we used to laugh when you had TomToms years ago and it just about took you off a cliff. When you think about navigation for surgery, the precision of navigation in tiny millimeters within the spinal cord. But it just takes a lot of cognitive load from the surgeon, the planning and education with the patient to be able to let you see your MRI and where some of those implants are going in to stabilise the spine. The lack of radiation in theatre, because so many x-rays are taken in standard open procedures. It's less trauma, because any surgery is actually a trauma to tissue. And surgeons do get cancers of the eyes and the shins, where the lead aprons don't protect, and we're getting a bit better with that. But if you think a patient themselves may actually have radiation exposure in that big long operation, of which a spinal operation could be 10 or 12 hours, we can reduce that by 3 or 4 with the cobot. And what used to take hours to get the metalwork in can be done in minutes.
It's incredible.
And minimally invasive. But secondly, I think what's interesting is those theatre nurses and doctors and radiologists and everybody who's all in theatre, they're exposed to radiation even with their lead aprons all the time. So there's many compelling reasons why the cobot would be an amazing acquisition for Australia. Now, there were 2 when I started the campaign, and now there are 5. But South Australia, we still don't have.
Right.
And then we could talk about endoscopic spine and day case. The whole world is converted to day case spinal operations.
So what does that mean?
That just means that you're able to use keyhole surgery, literally keyhole surgery, to get to the spine in tiny little apertures. And unfortunately for Australia, I would say unfortunately, because the health fund modelling is based on a 3-night stay.
Right.
So the private hospitals are paid for 3 nights.
Yes.
So whilst the whole of the world is moving towards day case, nobody wants to be in hospital for any longer than we want to be. Certainly post-COVID, we're very aware of infection and not wanting to be in hospitals because of infection or whatever. So really my campaign is, we have amazingly qualified, technically expert surgeons that actually require the technology. And that's before I even begin to talk about some of our work in AI in healthcare and the opportunity that AI can enhance some of our health outcomes.
Well, tell us about that.
So it's interesting. There's a couple of courses just now between Harvard and MIT looking at AI in healthcare. Some of the radiology practices are already looking at some of those large data modules where we're looking at x-rays, chest x-rays, mammograms and things. actually the AI can say this is normal. You know, these X-rays are absolutely normal, but this is one that you need to worry about, versus that of a consultant radiologist. And so some of the larger radiology practices are already running the bulk of their X-rays through AI. And then if you think about that, it's a revolution, isn't it, in time management?
Yeah.
Because then it's just actually picking that which is not normal.
I feel like that's the same with the cobot, where you can actually see more patients.
That's right.
Because it takes less time.
Yeah, well, you would be able to have higher volume through theatre.
Yeah, which is better for people.
Yeah, and waiting lists and everything. So yes, AI in healthcare is really, it's absolutely fascinating, thinking about how we might actually then begin to look at how we measure outcomes. What if we, as the best trained people with, you know, advanced skills and courses and knowledge, if all that amalgamated data went together and it began to tell us actually things that we could be missing, like predicting longevity, or the prediction that sort of, we talk about prehabilitation in surgery, which is a huge, enormous part of what we should be doing. We shouldn't just be focusing on the surgery. We need to be focusing on the whole patient journey and optimising health and mental health up to the point of surgery, if surgery is indicated, but surgery may not be indicated. I mean, in one in 10 patients in spine, 1 in 10 would be an average conversion to surgery, and 9 of those patients don't need surgery, but they need, you know, pain intervention or psychology or meditation or hypnosis or, you know, physio. You know, there could be a whole host of things that we can offer that can help that person's suffering. And when you look at AI, they could be predicting things that we just don't actually know. Yeah. And they could be predicting things earlier that would change the course of that patient journey. Yeah.
Fascinating.
It is, isn't it?
It is. So in your current role, what are the most significant challenges you face in advancing patient care? How do you envision addressing these challenges in the future? Because I do think you are always very future focused. And
I mean, we could talk a little bit about, I suppose there's economic factors and the cost of delivering healthcare, and certainly the cost of delivering healthcare in our particular point in history post-COVID, cost of living, you know, cost of health funds and all of those things are a particular challenge in healthcare, certainly amongst general practice, but also in specialist practice as well, that it's not that you don't want to be able to achieve lots, and we're obviously using a lot of our margin, you know, to run our international research and everything else. But you could really run as a not-for-profit, to be honest.
Yeah. So how does the international research work within your group? Yeah.
Well, we started the company 3 years ago. It's been quite a phenomenal direction to go in, because we have about 1,800 episodes of care per month at International Spine. So if you imagine that sort of cohort of patients from age 14 to, I think our oldest patient was 97, 98.
Wow.
It's amazing. And 80% of Australians will have some sort of challenge or difficulty with their spine at any point in their life. So none of us are really immune to a spinal problem or back pain. Cross our fingers that we don't get one. But still, if you think about the cohorts of patients coming through, and then particularly from the US, Australia has really come on the radar for international research because of pressures within Europe and the US. And also our TGA is super rigorous. And so if an implant or various other, you know, maybe a pharmaceutical agent or something of that nature is rubber stamped by the TGA, that fast tracks it through the FDA. And so for us, we had this interdisciplinary model. And so if we were measuring the outcome, or, you know, looking at, I was speaking about back pain and diabetes, for instance, 80% of diabetic patients will develop some form of chronic low back pain, or indeed neuropathic or nerve pain in the legs. So we're looking at, you know, a spinal cord stimulator just for diabetic patients at the moment to help them with their pain, because they can't sleep at night. It keeps you awake all night. It's dreadful. So the research work has taken us in directions in pain management that I couldn't have envisaged. But through that academic inquiry, it's been interesting because what's attracted many people to work with us is the interdisciplinary model, because then you're able to measure from a movement perspective or a mind perspective, the surgical perspective.
So much more data.
Yeah, that's right.
You collect.
And across all the disciplines, whether it's psychology, counselling, the dietitian, exercise physiology or physio, and plus all the medical specialties. So therefore, it was unexpected for me when people were asking me about pathways of care. And I said, well, we intentionally design a patient journey on a pathway. Well, you can then bolt on research methodology onto that. So, I'm delighted.
But it was
absolutely
an
delighted.
Unexpected.
Yeah. And whilst I always had this sort of future pioneering spirit, to be able to integrate that into our work, it sort of, just brought a further excitement to the possibilities of helping people now and in the future as well.
Well, we've talked about your experience sort of starting out clinically, moving towards change management, then starting a business and really becoming very entrepreneurial in healthcare. What would you say your one hack is for entrepreneurs, having been one now for 10 years?
Okay. I would say my one hack is that as you're building your relationships, the most important thing is actually to do what you're going to, you say what you're going to do, you do what you're going to say, because you meet so many people, you form these relationships, and you sort of live or die by your integrity, Sarah. And when we're going through, so many people come through your life, you have to kind of sometimes take a bit of a step back and then have the ability to say in that relationship, is that something you're always going to nurture? And I've found it, I don't think being an entrepreneur is without its personal pain, because you then have to become so aware of the human psychology. There's a darker side to it where people always want a bit of you, or there's something in it for them. People always have an agenda and they drive that agenda, but you have to always try and live by, doing what you say.
Yes.
And so true. I think a hack is just to, if I could share anything, is just to be so acutely aware of your relationship management, and to be able to just be true, both to yourself, to walk away when you need to walk away, and listen to your intuition in that about the people that you're connecting with, the people who are genuinely on your side and those who are not.
Yep, it's beautiful. I love it. Thanks so much for coming in today.
Thank you.
We're going to keep the conversation going in our private Facebook group, You Legal for Doctors. You're welcome to join us there.